The second presentation will be by Dr. Gordon Siu, and Dr. Siu is the nephrology specialist and associate consultant in Jubilant Hospital, and he will highlight us on the advance in diabetic management. Dr. Siu.
First, I would like to thank Dr. Ho for inviting me to present the lecture, and also thanks Dr. Min for the introduction, and thanks all to come today. Today's topic is advances in diabetic management, and I've already asked Dr. Ho whether it's advances in diabetic nephropathy or is it advances in diabetic glomerulonephritis or the management, and Dr. Ho said this year we will do something new, so I will talk about the advances in diabetic management. And in case it's just advances, so I will only talk about the very new maybe drugs or techniques or treatment within this 1 to 2 years time, and I would like to share it with you. So I would like to have 4 major topics today, and I will see whether we have time to finish all that. The first one is the incretins, and I think all of you will know that, and I will come back to it later. The second one will be the sodium glucose co-transporter 2 inhibitors. The third one is the use of the insulin pump and also the continuous glucose monitoring. And the last one is the very new treatment for the DM macular edema. So let's come to the incretins first. Incretins are in fact gut-derived hormones. When we eat a meal, and the gut will secrete the incretins. And the duration of action is in fact very short, and they have a very short half-life of only a few minutes. We have 2 gut hormones that we now know. The first one is the GLP-1, and the second one is the GIP. The GIP is mainly secreted in the proximal GI tract from the duodenum and also the proximal jejunum. And for the GLP-1 that we are more familiar is being secreted by the L cells in the ileum and also the colon. So the incretins, in fact, our body has a lot of receptors for these kinds of incretins, and not only is the pancreas. And we have the islet alpha and beta cells in the pancreas, the GI tract, the central nervous system, the heart, the lung, and also the kidneys. So we now know that this GLP-1 protein has a lot of effects, and they affect our brain so that we do not want to eat and decrease our appetite, and also decrease the stomach transit time, and so have a feeling of fullness of the stomach after a meal, and we do not want to eat. And the most important of all is that it can preserve the beta cells. You all know that the sulfonylurea, like the diamicron, the daon, are bad because they kill our beta cells. And however, we now know that the GLP-1 can preserve the beta cells because probably they decrease this beta cells apoptosis. And also, it has some kind of cardiac protective action, but we still don't know. And ongoing studies are still around the world to see whether patients receiving this GLP-1 will have a cardiac protective effect. So these are all the effects of this GLP-1 hormone. So come back to the DM control. For this GLP-1, it has 5 types of, or 5 ways to control our diabetics. The first one is stimulate the glucose-dependent insulin secretion, and also to improve the first phase insulin response. What do you mean by the first phase? Is that it's the phase when you eat, after you eat your food, the insulin has a surge, and in this 5 or 10 minutes or in the first half an hour, we call this the first phase response. And for type 2 DM patients, you have a very poor first phase response. That's why after you eat your meal, you have a kick up of the blood glucose, right? And that is dropped slowly. So that's the first phase response. And also suppress the postprandial glucagon secretions from the alpha cells, slow the gastric emptying, and also act on the brain to reduce the food intake. That's why the GLP-1 can help you to lose your weight. And now we know that we have 2 types of incretin-based therapies. The first one is what we call the incretin mimetics. That is that you give the patient exogenous incretin, that is to inject the GLP-1 to your patient. The second one is that you increase the degradation of this incretin, that is act by inhibit the degradating enzyme, that's the DPP4. So these simple charts tell you that we have the increasing the GLP-1 with the response to lowering the blood glucose by all means, and we also have the DPP4 enzyme to degrade the GLP-1. So either we give your patients the GLP-1 directly, or you give a drug to inhibit the DPP4 enzyme, so that increases the half-life and the lifetime of the GLP-1 in your body, but provided that you have enough GLP-1. So if you do not have enough GLP-1, then blocking the degradating enzyme is of no use. So now we have the two types of treatment. The first one, on the left side is the small molecule of the GLP-1, and on the right side, the blue monsters is the DPP4. Right? You can see there's a hole inside because it's where the substrate goes in to inactivate. So we have the incretin-based therapy. The first one is the so-called incretin mimetics. There's the GLP-1, and we'll talk on this first. So this is a GLP-1 therapy, but unlucky is that this is a hormone that you give, so you cannot take it by your mouth because it will be being degradated. So you have to give it by a sub-Q means, just like an insulin. So the problems come because your patient do not want the insulin injection. That's why you start the patient on this kind of new drugs. But now you tell them that no, sorry, you have to inject again. But what's the point of using this GLP-1 injection? We now have some forms of GLP-1 agonists that we say. The first one is the exenatide. Exenatide is the FDA approved way back to 2005, so it's nothing new. It's not the advances in PM management. And the second one is approved in 2010. Is liraglutide. And nowadays we have a long-acting ones. This is the latest one that is approved by the FDA last year. Is given 1 weekly. There is an extended release of the exenatide. So this is the trend of this GLP-1 agonist. Is that starting from 2005 back in the 2005 days, and now we have given 2 times a day in 2005, and then once a day, and then we have now once a week, and then now we already have a monthly suspension. That is like a depot. That is to give the patient a monthly GLP-1 injection is okay. So we can see that how is the effect. Right? You can see the comparison of the HbA1c reduction. The first one is the short-acting exenatide. It's reduced the HbA1c to 0.5 to 1%. The second one is the longer-acting GLP-1 agonist and reduced the HbA1c by 0.8 to 1.5%. And now we have the long-acting one. This is the weekly exenatide that is given once per week, and we can decrease the HbA1c up to 1.9%. And another effect of this GLP-1 agonist is that you can decrease the body weight as well. You can see that for the exenatide, you can decrease up to 2.8 kilograms, and for the extended release up to 3.7 kilograms. And I know that in the US, people are already giving this kind of drugs to their patients to lose weight only. They do not have diabetes, just to lose weight. And of course, I do not recommend you to give this kind of drug to your patient just because to lose weight. But it is effective. Right? You can decrease your HbA1c, and also you can decrease your body weight. So how about the safety of this GLP-1 agonist? It's rather safe. And however, if your patient got a renal impairment with a creatinine clearance less than 30 mL per minute, then you have to reduce it by half. And since we now know that the GLP-1 agonist will slow your food transit in your stomach, so if your patient got a gastroparesis, it's contraindicated to this kind of GLP-1 agonist. And in rats, because our thyroid also got this GLP-1 receptor, and they stimulate these thyroid cells to proliferate. And this can be shown only in mouse that it can cause medullary thyroid cancer, but in human being it's still not known. And this is the latest FDA guidelines this year, 2013, is that the patients will be contraindicated for this kind of long-acting GLP-1 agonist if you have a personal or family history of medullary thyroid cancer. or if you have an MEN2 type of endocrine neoplasia. So if you started your patient on this GLP-1, you need to monitor because there's a risk of thyroid cancer. But however, they say that even if you monitor it by either ultrasound or by blood test, it's useless. They don't know when should, or how frequent you should have monitored your patient to have an ultrasound of the thyroid. So the main point is that you have to counsel your patients that they know the risk of this drug before you start them on this GLP-1 agonist. The risk is low and it's only in rats model, but there is definitely a risk of inducing a thyroid cancer with this GLP-1 agonist. So after talking about the GLP-1, now we come to this DPP-4 inhibitors. So this is all the DPP-4 inhibitors. You can see that it is already an old drug. FDA approved the first one, the sitagliptin, is already in 2006, and our partner, the Novartis here, have their glyphosate in 2007 in the Europe, and then we have the saxagliptin in 2009, and the latest one are these two is the lingagliptin and the elogliptin. Elogliptin is the latest. It is just approved this year. So what's the difference between these all kinds of DPP-4 inhibitors? In fact, they are just similar. On the left-hand side is what we call a little bit old, 2 or 3 years time, DPP-4I, is that they have a peptidomimetic inhibitors. And on the right side, there is the latest 2011 and also 2013 is direct binding to the DPP-4 site, active site, to cause the inhibition. So this kind of so-called newer DPP-4 inhibitors have longer half-life and claim to be more specific because it can more specific act on the DPP-4. We have all kinds of DPP-4 in our body. And on the left-hand side, it can also inhibit DPP-8 and also DPP-9 enzymes. And maybe they have another benefit, we don't know. But on the right-hand side is a specific DPP-4 inhibitors. So what's the difference between this DPP-4 when we compare to maybe what we all know is the metformin? The DPP-4 inhibitors will enhance the beta cell to secrete the insulin and also suppress the alpha cell to have the glucagon response, and also lowers the hepatic glucose production, but it cannot improve the insulin resistance. And they all have very low risk of hypoglycemia, and so it's very safe. And unlike the GLP-1 agonists, they are so-called the weight neutral, is that they will not induce increase in body weight, but they cannot help you to lose weight. But it's already a benefit because you know that if you start the patient on Daonil, they get fatter and fatter, and your Daonil soon will of no use, and you have to change it to insulin. So we have the lingagliptin. We all are being excreted by the kidney, except this new DPP-4 inhibitors that is excreted nearly unchanged by the bile and the gut. So even if you have an end-stage renal disease, you can use lingagliptin with just a normal dose. And you can also use the other gliptins, like the vitagliptins or the sitagliptins, in end-stage renal disease or patient with renal impairment, but you have to reduce the dose. Otherwise, they are just similar. Right? Lingagliptin is just do not need to adjust the dose. That's a little bit of benefit. And also, as it's excreted unchanged in the bile and the gut, it's not degraded by the liver. So even if you have liver failure, you can also use this drug, and you do not need to alter the dosage as well. So we'll see how about the so-called new fashion or the latest. There's the elogliptin, right? Just approved this year, right? Is it that good? Right? How about that compared to this vitagliptin? We can see that in HbA1c, in fact, it's just similar. After about the 24 weeks treatment, the HbA1c decreased by 0.8% by the vitagliptin, and also similar to the elogliptins. They can be used once daily. That's why there's a longer half-life. That's the only benefit. So the livergliptins have a longer half-life. You can take it just once daily. Theoretically, it's more specific for DPP-4 and will not inhibit DPP-8 or DPP9, but whether we know that they are benefit or not, we still don't know. And we have to know that this does not mean that the newer gliptins are any stronger than our old gliptins, just because they have different mechanisms only. So you see that this so-called new gliptins, the linear gliptins, you can see that for the international studies, it's decreased by only 0.7%. And even if you add on metformin, add on sulfonylurea, or the triple combo, add on metformin and sulfonylurea, all are similar. It's just a 0.6 to maybe 1% decrease in the HbA1c. So DPP4 inhibitors are what now we call a weak glucose-lowering agent. The HbA1c decreased by about 0.6 to maximum 0.8 or 1%. But however, they can be taken orally. They do not like the GLP-1 that you have to be injected subcutaneously. And it's easily tolerable, and they usually don't have much side effect. At least they are weight neutral, that they will not gain weight and rarely hypoglycemia. So you start the patient on metformin first, right? And then second line usually we add on maybe a DMA or diamycron sulfonylurea. But if the patient is fat, or maybe you're afraid of the hypoglycemic attack, then you can start the patient on either directly on gliptins or metformin plus the gliptins, and it's okay. So this is a comparison of all the drugs that we have. These are oral drugs, and only the insulin is on the right hand side. You can see that metformin decreased by 1.5%, sulfonylurea similar. The third one is the glitazones, the pioglitazone, the actors, decreased by 1%, and the GLP-1 is 0.8% around. DPP4 is also similar. And the least useful that we call in the decreasing HbA1c is the argables. So after talking about the incretins, another new drug is in fact another new class of drugs is the sodium glucose co-transporter 2 inhibitors. So what's this drug? This is just approved by the FDA this year in March. So it's a very new drug. Dr. Ho asked me to introduce that once. So this is a very new drug, just approved a few months ago. This is called the plenaglyphosine. Right? What is the mechanism of this drug? In fact, simply, it just excretes in the urine the glucose. Right? In fact, our body always have 糖尿病, right? You have the urine glucose. In fact, it's a self-defense mechanism. Right? When the blood glucose is very high, your body responds to excrete all the glucose out. In fact, this is good. What in the past, what we are doing is that we stimulate our beta cells, we inject the insulin to tackle the hyperglycemia in our blood. But this is absolutely a new idea that we do not increase our insulin, we do not affect our beta cell, we just excrete the additional glucose away. Right? And the site of action is the proximal renal tubule. So most of the time our glucose, because it's very small, it can be filtrated nearly 100% into the glomeruli. And the proximal tubule, we have this SGLT2 receptor, and 90% of this glucose is being reabsorbed. And in the distal tubule, the remaining 10% is reabsorbed. So most of the time, in a normal person, you do not have glucose in your urine because they reabsorb 100%. So now you know if we have an inhibitor to inhibit the SGLT2 receptor, then 90% of your glucose being filtrated will then pass through in the urine and then excreted out. So what's the use of this? Because if you have this inhibitor, you can inhibit this glucose reabsorption and you can pass out about 50 to 80 grams of glucose a day. And because when you excrete your glucose out, it's an osmotic agent, right? You need to excrete water as well. So at the same time, you excrete more water out, right? So you decrease your edema and lowers your blood pressure. And because glucose is something with calories, so in fact, you excrete 50 to 80 grams of glucose a day, you lost quite a number of calories. So in fact, you can also decrease your body weight. And for HbA1c, maximum you can decrease by about 1%. And because of this unique mechanism, you can combine this new drug with any kind of drugs that is previously FDA approved, whether it's oral drugs, insulin, GLP-1, DPP-4I, whatever. So this is the effect of this GLT2 inhibitors, right? It can have a weight loss of about 5 to 10 pounds, that is about 2 to 4 kilograms. Increase your blood pressure by 4%, slightly increase your HDL and increase your LDL as well. So this is a comparison of all the oral agents of the drugs that we now have, including the new SGLT2 inhibitors. Because time is running short, we will talk fast. So with the first year SGLT2 being approved this year, we have another one that's approved also just a few months ago, is the Boehringer. And the Europe has also approved the BMS, and there are two going, maybe approved next year. And now we come to see what's new of this insulin pump. For this insulin pump, we need to, of course, have a pump, and then you need to have a tube set, and also you need to have a needle. And how this works is that you put the needle in the subcutaneous and then connect it to the tube, and then connect it to the insulin pump. And then it will program and pump the insulin to you 24 hours a day. And it's only indicated in type 1 DM. At the same time, because it's 24 hours working, you need to have monitoring of your glucose. So you need a continuous glucose monitoring as well. And you need to, you also have a very small needle and check the subcutaneous tissue fluid, not blood glucose, subcutaneous tissue fluid glucose, and estimate the blood glucose. So it's also put underneath your skin. So if your patient have a continuous glucose monitoring and also an insulin pump, the patient will look like this. And the continuous glucose monitoring sensor will send all the signal to your insulin pump. Right? Perhaps if you stop the insulin pump if the glucose is less than 3, right? Then you stop. You will not run into hypoglycemia. Right? So what's new about this insulin pump? This is the newly FDA approved insulin pump last year. This is the only pump without a tube, and no tubing. That is, you have some hand phone or cell phone like operator, wireless, right? You do not need a tube anymore. You inject your insulin to this very small insulin pump and then stick it to wherever you want to, stick it to the abdomen, and then push a button. And push a button and they will stick 2 needles in. The first needle is the insulin needle, under the subcutaneous tissue, and the second needle is the continuous glucose monitoring needle, so as to control your blood glucose. So in the gray one is that your blood glucose, right? You can see that when you slept and after 12 midnight the glucose starts to fall, and so you can adjust the green line, there's an insulin pump, to have less glucose being pumped at night. And before each meal, they usually have a program that you can adjust so that before breakfast, lunch or dinner, you pump maybe a few more units of this insulin to tackle that meal. And finally, I will touch just a few slides on diabetic macular edema. You can see we have the optic disc there, and this is the macula. And for when you look at the patient with macular edema, the frontal, you can see all this whitish shadow, right, cotton wool-like, and there's the edema. In the past, we do not have any drugs for this macular edema. And you can see in the middle, there's a normal macula that's indented in the retina. And when you have the fluid accumulate between this retina and the macula, and in the macular area, you have a swollen macula. Right? In that point, when you see it, the front eye will turn white, cotton wool-like, and that is the edema. So what will you look if you have this kind of macular edema? Either it may be the first one, because it split the retina, so you see some patches, right? Or the second one is that you have some color changes, right? Or the third one, it distorts your image because it affects your macula. So this is the latest FDA-approved drug. It's the only drug that's being approved for this diabetic macular edema. It's a monoclonal antibody. It's called the ranibizumab. Right? When you see MAB, you know it's a monoclonal antibody. So how it works is, in fact, a vascular endothelial growth factor A antagonist. From the investigators, we know that we have the macular edema because we leak fluid out from the blood vessels, and this VEGF-A plays a role. So we inject this kind of antibody into the eye directly, and then they will block this kind of VEGF-A and stop all the fluid comes out. And the advantage of this is that once it leaves your eyes and into the bloodstream, it's being inactivated at once. So it should not have any systemic symptoms. It has been said that if you do not receive this kind of drug, you will see the left-hand side with a patient with diabetic macular edema, you see just to the V. And if you have this kind of injection, the studies claim that you can have 15 more characters and improve in the visual acuity, and that improve the diabetic macular edema. And so this ends my presentation. Thank you very much.
Thank you, Dr. Siu. Is there any question directed to Dr. Siu concerning diabetic treatment?
No, sir. Any effect on the CD if you take this DDP inhibitor?
You mean on the central nervous system or the cardiovascular system?
Cardiac.
It now claims that you have a protective effect, but studies are ongoing. Large studies are ongoing, and they claim to have a protective effect. Unlike the glitazones, you know the glitazones, they have an increased risk of myocardial infarction and also heart failure, so the rosiglitazone has already been banned. Plioclitazone has also a slight increased risk, but it's still used because it's not statistically significant. However, for the GLP-1 only, they have a protective effect of the heart. But the DPP-4, they are still doing the GLP-1 agonists on the cardiovascular system, as well as the DPP-4 inhibitor, and maybe the result will come in the future 1 to 2 years' time. And they claim to have a beneficial effect on the heart, to have a decreased atherosclerosis.
If not, we'll thank Dr. Siu for his lecture.